Buenas tardes a todos, bienvenidos. Good
Good
afternoon,
afternoon,
everyone.
everybody.
Welcome. Thanks for joining today. Estamos muy contentos de poder ofrecerles
Very happy
interpretación
being able to offer
varios
you
idiomas, en inglés y
interpretation
español,
in English
para
and
este seminario
Spanish
web.
for this
Por favor,
webinar.
diríjanse al icono de
Please go
interpretación
to
que está
the
ubicado en la parte
interpretation
inferior de la
icon
pantalla
at
del
the
Zoom.
bottom right of your
Allí pueden
Zoom
seleccionar su
screen.
idioma de
There you
preferencia,
can
inglés o
choose
español,
the
para
language
escuchar la
you
sesión
prefer, English
en
or
forma cómoda.
Spanish, to listen to the
We are
session
pleased to offer language
comfortably.
interpretation for this webinar. Please note that the interpretation icon located at the bottom of your Zoom screen, click there and select your preferred language to follow the session comfortable. Welcome, everyone. We are going to start in a couple of minutes. Buenas tardes, bienvenidos. Good afternoon, welcome everyone. El webinar contará con traducción simultánea en español e inglés.
The webinar will have simultaneous interpreting in Spanish and English. Please select the interpretation icon that is at the right bottom of your Zoom screen and choose the language you prefer.
So please go to the interpretation icon located at the bottom of your screen, Zoom screen, click it and select your preferred language to follow the session comfortable. Thanks for joining today. Muchas gracias por unirse. Bienvenidos. Welcome everyone. Verónica, the floor is yours whenever you want.
Ok, muchas gracias, Claudia. Bueno,
Okay, thank you
buenos
very much,
días o buenas
Claudia.
tardes
Good
a
morning
todas
or
y
good
todos
afternoon
y
to
muy
you all.
bienvenidos. Mi nombre es
Welcome.
Verónica Dussel
My name
y
is
es un placer
Veronica Dussel,
acompañarlos
and
hoy
it's a
en
pleasure to be
representación de la
with you
International
today,
Association of Hospice and
representing the
Palliative Care,
International
la
Association of
IHPC.
Hospices and
Desde la
Palliative Care,
IHPC estamos trabajando para promover el
IHPC.
acceso
We are
universal a los
working to
cuidados
promote
paliativos a
universal
través de la
access to
educación, la
palliative care through
investigación, la
education,
promoción de
research,
políticas públicas y el
promotion of public
fortalecimiento de redes
policies, and
entre
strengthening
profesionales,
of networks
instituciones y
among
organizaciones
professionals,
comprometidas
institutions,
con
and
aliviar el sufrimiento grave
organizations that are
relacionado con la
committed
salud.
with relieving
Quiero agradecer hoy
serious
especialmente a
suffering
la
in
Organización
connection to health.
Panamericana de la
I'd
Salud
like
y a
to
todas
thank
las
PAHO
personas, somos
and
un
all
montón aquí
the
atrás, que han
people,
hecho posible este
lots
espacio
at
y
the
forman
back
parte de
end
una
that
serie
have
de seminarios
been
orientados a
that have
fortalecer
made
la
this
integración de los
forum
cuidados
possible
paliativos en la región.
to strengthen the integration of
Según la
palliative
actualización más
care across
reciente
the
del
region.
estudio sobre
According
sufrimiento grave
to
relacionado a la
recent
salud, o
updates
como
on
también lo
serious
deben
suffering
conocer,
related to health,
SHS, por sus siglas en
SHS,
inglés, Serious Health Related Suffering, que fue publicada en The
serious health
Lancet,
related
de las 9
suffering
millones de
published in
personas
the
que
Lancet. Out of
fallecieron en
the
las Américas
9
en
million people
2021,
who died in
3
the Americas in
millones
2021,
casi y
3
medio de
million
personas murieron con
and
este tipo
have
de sufrimiento
died
y
with this
habrían
kind of
requerido
suffering
cuidados
and would
paliativos para
have
su alivio.
required
Esto
palliative
equivale, para que
care
tengan una
for
idea, a
their
más de
relief.
una de cada 3
This
personas
is
fallecidas en la
more than
región.
one of
El
every
tema que
3
nos convoca hoy,
people
el
who
lugar
died
de
in the
muerte como
region.
indicador de
So
acceso a los cuidados
instead
paliativos
of
en América
death,
Latina,
what
es
we want to see
particularmente
is the
relevante
indicator
porque se trata
of
de un
access to
dato que es
palliative
relativamente
care.
sencillo de
It's
relevar y que al
simple
mismo
to
tiempo nos permite
get
abrir
this
múltiples
datum,
preguntas
and it
acerca de cómo
opens
se
a number of
organiza la
questions
atención al
is
final de la vida.
how we organize
Los
care
estudios sobre
at
el
the
lugar
end
de
of
muerte en
life.
nuestra región
Studies
muestran
of
una
places of death
considerable
in our
variación entre
region
países
show
e
a great
incluso
variation
dentro
among
de un mismo
countries and
país,
even inside
lo que
a
probablemente
country.
refleje
This
diferencias en la
probably
organización de
reflects
los sistemas de
differences
salud
in
y
the
en la disponibilidad
organization
de
of healthcare
servicios.
systems
A lo
and
largo de esta sesión
service
vamos a explorar esta
availability.
cuestión
We're
desde
going to
distintas perspectivas
explore this matter from different perspectives. First of all, reviewing evidence and patterns observed in Brazil, then we'll go in depth in the pediatric reality in Latin America, and finally reflecting on how to translate these findings in concrete actions and public health strategies helping to relieve suffering in connection to health. In the HPC, we deeply believe in these forums, opportunities to learn from each other, strengthen our capacities, and continue building a global community committed with PC in healthcare systems. Thank you very much for being with us today. And we start the session now. Dr. Fernando Marcucci is a physical therapist. He has a PhD in public health. He works in the state of Paraná in the hospital on palliative care, and he'll be talking about the place of death from the perspective of what happens in Brazil. Fernando, you have the floor.
Hi, everyone. I will share my presentation. Everyone is seeing the slides?
Yes.
Okay, I will talk about the place of death as indicator of access to palliative care in Latin America. My presentation will be mostly in English. I'm very grateful for the invitation of Pan American Health Organization, International Association for Hospice and Palliative Care. I work in a medium complex hospital in the south of Brazil, the city of Londrina. And I will talk how we have it dealing with the end of life and our research with place of death as indicator to see how people have dealing with end of life care in Latin America countries. We have to remember that Latin America have 20 countries and a population of 672 million people. That's about 8% of world population. Brazil alone have a population of 213 million people. That is 1/3 of Latin American population. And Mexico is the second largest country, 132 million people. In Latin America, 86% of the population is considered to be living in urban areas, and 100 million people have over 6 years old now. That is about 14 to 15% of the Latin America population. In previous studies performed by our research group with representative of many countries and coordinated by Professor Tania Pastrana from Germany, we have done some research about how deaths is registered in those countries. In this one, we have evaluated the quality of the data available from death certificates in 13 countries in Latin America, where the quality of the data was considered high for 3 countries, medium for 7, and low for 3. And the rate of data registered without information about place of death was between 0 to almost 6% in most countries, with the exception of Peru, where 25% of the information about place of death was missing. But overall, we consider that this data available from these countries are enough to make comparison among them and with other regions of the world. After that, in a comparison with 12 Latin American countries, we identify that place of death have a high variation between American Latin countries, And the proportion of deaths at home ranged from 20 to 68%, and the proportion of deaths in hospitals varies from 22 to 69%. So it's a huge variation among the countries. Even in the same country, there's a difference between regions. After that, some different research have been done with a specific population like dementia, people with cancer, and people with chronic conditions, and more details can be accessed in those published articles. Now, as an example of how we are evaluating the place of death distribution in a country, in those cases, I will talk about Brazil and how we have dealing with the end-of-life care here. Brazil have many demographic challenges. For example, the inequalities in the distribution of the economic and social difference in the country. For example, Brazil is geographically divided in 5 regions: North, Northeast, Central-West, Southeast, and South. And here we can see a map of the difference in Human Development Index, HDI, where the North states have a considered medium HDI, while the South states are considered as high. In the last populational census, when you consider the classification of ethnic and color scheme in Brazil, according with our National Geographic and Statistics Institute, 45% of the population was considered brown or mixed, 44% are considered white or yellow. Yellow is less than 1%. Black people is around 10%, and indigenous or traditional people around 0.8%. Population over 65 years old now is around 11% and expected to increase in the next decades until 18% in 2040. That is like in many countries in Europe now, and 31% in 2070. That is close to what Japan have today. Life expectancy have been increasing over the last years, and now it's about 76 years old and expected to be around 84 years in 2070. When you consider the distribution of place of death in Brazil, we see that it's a distribution very dichotomical allocation, since we don't have many options of other healthcare settings in Brazil. So it's mostly divided between hospital and home. When you look over the last 2 decades, we see that death at hospital have been maintaining around 64 to 66% of all deaths, while deaths at home have decreasing over the time from 24 to 20% now. We can see that deaths in other healthcare settings have been increasing, but it's still a very small proportion of those all deaths. That is about 70.3% now. So we can see that a worry in our country is that death allocated at home in a place where we don't have structured home care, for example, can be an indicator of lack of access to professional and palliative care in those regions. For example, when we compare among Brazilian regions, death in hospitals varies between 68% in South to 58% in Northeast, a difference of 10%. In Northeast, there's a higher proportion of deaths at home, 27%, and lowest in the Southeast, 70%. 71% of all deaths are over 6 years old and have a highest proportion in the South, where the states have a high proportion of elderly in population, and lowest in the North region, around 59%. And there's a shift of the occurrence of death from hospital to home in the older age groups. It means that over 8 or more years have a higher proportion of deaths at home when compared with people from 60 to 69 years old. Women usually have a high proportion of deaths at hospital when compared with men. And when we see another social factors, for example, lower educational status, have a lower chance of dying in hospital. And white people have a 1.2 times higher chance of dying in hospital than home when compared with non-white people. So we can see the difference of social, economic, and demographic differences in the allocation of how people deal with the end of life. In previous studies by economists in 2010 about the quality of death in those 40 countries, we see that Brazil reached a 38th position. It's a very low grade of evaluation of the quality of the support offered in the end of life, next to Mexico, for example. In a study of Finkelstein and colleagues in 2021 about the quality of death and diet, in a comparison with 81 countries, Brazil reached the position 79. So we're not proud of that, of course. Next to Bolivia, Haiti, and Paraguay in the Latin America region. So we can see that Brazil has too much to advance and to provide a better quality of support in the end of life in palliative care. Since then, we can see that when in 2014, when WHO published their palliative care resolution, in that year, in the Global Atlas of Palliative Care at the End of Life from WHPCA, Brazil was classified in the category 3B, 3A, with an isolated provision of palliative care in the health system. In 2018, in a commission of public managers, including the Minister of Health, published the National Recommendation Guideline for the Organization of Palliative Care within the Unified Health System, or SUS, that is Brazilian Public Health System. In the second edition of the Global Atlas of Palliative Care in 2020, Brazil was classified in a category 3B that provides a generalized palliative care provision, but without the integration in health system. And finally, in 2024, regulatory ordinance established the National Palliative Care Policy in Brazil within the scope of the SUS. So for the first time, we have a specific budget to support the palliative care teams in the healthcare services. But we know that there's still very few palliative care teams in this specific policy. Since we have many palliative care services that is not still registered in this national law. After that, in a global ranking of palliative care by Tripodoro and colleagues in 2025, Brazil was considered as level of palliative care development as established country, but not yet in advanced condition since we don't have integrated services in the health system. So as you can see, the public policy in palliative care in Brazil is still recent, and we hope that we have improvement in next years to provide a better quality of end-of-life care in Brazil. So these are the references used in my presentation. And here, some links of our National Academy of Palliative Care, so we can see the actions that have been done in the country, and the website of Ministry of Health, where with more details about the National Palliative Care Policy in our country. Thank you very much for your attention, and I will be available for any questions after the other speakers.
Muchísimas gracias, Fernando. Muy
Thank you very much,
interesante
Fernando.
la ponencia.
Your presentation was very interesting.
Las
Questions
dejamos para el
then
final y
are
ahí
left
hacemos
for the end, and then we'll moderate all together.
Le quiero dar la bienvenida
I'd
ahora
like
a
to
Jimena
now
García
welcome
Quintero, que es
Jimena
pediatra y
Garcia
especialista
Quintero.
en cuidados
She's a
paliativos,
pediatrician
formada en
and
Colombia,
specialist
que
of
actualmente se desempeña
palliative
como
care.
directora del programa
She studied
global de
in
cuidados
Colombia, is
paliativos en el St.
currently
Jude's
director
Children's
of
Research
the
Hospital en
global
Estados Unidos.
program on
Desde allí
palliative
impulsa iniciativas
care
globales
in
de
the
educación,
St. Jude's
investigación
Hospital
y
in the
mejora
United
de la
States.
calidad
She works on
para ampliar el
research
acceso
and
equitativo a la
quality
atención
improvement
para niños con
to broaden
enfermedades.
palliative
Adelante,
care for caring
Muchas
for
gracias,
children with
Verónica, y gracias a
serious
todos por
diseases. Thank you very
acompañarnos
much,
el día de
Veronica, and
hoy.
thank you to you all
Hablaré en
for being with us
representación
today. I'll
del
speak
Programa Global de Cuidados
in
Paliativos
representation of the
del
global
Hospital
program of
St.
palliative
Jude.
care in St. Jude's Hospital.
En nombre del director,
On
el doctor
behalf of
Michael
the
McNeil,
director,
y
Dr.
del resto
Michael
del equipo.
McNeil, and
Entonces, permítame compartir mi
the
pantalla.
rest of
¿Me
our
puedes
team. Let me
confirmar,
share
Vero, si
my
estás viendo
screen. Vero,
adecuadamente?
can you see it?
Perfecto.
Yes, perfect.
Perfecto, gracias.
I see it perfectly
Entonces,
well.
Como
So,
dijo Verónica, voy a hacer
as Veronica
énfasis
said,
en los
I'll
datos de la
emphasize
población pediátrica
on
de nuestra región,
pediatric
del lugar del
population data in
fallecimiento
our
como
region,
indicador de acceso a los
place of
cuidados
death
paliativos en
as
América
an
Latina.
indicator of access to palliative
Entonces,
care in Latin
aquí
America too.
quiero empezar con unas cifras que
I'd like
son
to
muy
start with some
llamativas porque
figures
millones de
that call
niños
our
sufren
attention
y
because
casi
millions
todos
of
están muy
children
lejanos de
suffer
nuestras
and
miradas. Este es
almost
un
all are far
estudio
from
reciente
our
publicado por
gaze.
la
This is a
profesora
study
Julia
published by
Downing,
Professor Julia
en
Dunning.
donde estiman que
There,
10
she
millones de
estimates
niños
that 10 million
experimentan
children
sufrimiento severo
experience
relacionado a la
severe
salud. Son datos de
suffering related to
2023.
health.
El
SHS,
96%
this
de
is
ellos
data
viven
from
en países
2023.
de bajos y
96%
medianos ingresos
live in
como
low
la
and
mayoría de
medium
los
income
países de nuestra
countries,
región, y
as
solo el
most
10 al
countries in our region.
15%
Only
logra
5 to
acceder a los cuidados
10%
paliativos que
do
necesitan.
access
Estos 10
palliative
millones
care
de
as they
niños,
need.
que parece una
These 10
cifra
million
inimaginable,
children,
representan el
an
14%
unimaginable
de todo el
figure,
sufrimiento
represent
severo del
14% of
planeta. Y
all
esto
the
no ha
serious
cambiado en los
suffering in the
últimos 30
planet, and
años.
this hasn't
Y es
changed
por
in the last
esto
30 years.
que es
This
importante
is
que nos
why
reunamos a
it's
hablar
important
de
for
esto y
us
sobre todo
to
de cómo lo
gather
estamos
and talk
abordando.
about this and how
Cuando
we
tratamos a
deal
los
with it.
niños como
When
adultos
we
pequeños, en
treat
realidad todos
children as
perdemos.
small
Y
adults, all of us
estas
lose.
noticias parecen ficción, pero es que es la
These
realidad, no
news
solamente de mi país,
look like
Colombia, en donde
fiction.
estamos
This
en
is
una
the
crisis del
reality of my
sistema de
country,
salud
Colombia, where we have a
profunda, sino que
public
además esta
health
crisis se refleja en
crisis
otros
that is
países de
very
la
deep.
región, como
But
lo
also, this
podemos ver en estas
crisis
noticias.
is
No
reflected in
solamente
other
que
countries
cierran
in the region, as we
unidades
can see here
de
in
pediatría
these
en
news.
muchos
They
hospitales
close
de la
pediatric
región,
units
sino que
in many
también
hospitals in the
el
region, for
talento
example.
humano, los
Also,
pediatras
human talent,
están buscando otras
pediatricians,
alternativas y
are
otras
looking
oportunidades
for other
precisamente por esa falta
opportunities and alternatives,
de recursos.
particularly
Y
due
más
to
allá,
this lack of
Un
resources.
minuto. Estamos con un problema que hay gente que no escucha.
There are people who can't
Perdón.
hear you.
no hay problema.
Pienso yo que puede ser
I
porque estuvieron
think
escuchando en el
perhaps
canal
it's
de
because they
traducción al
were
inglés
listening
y que
to
deberán ponerse en el
the
canal general, pienso.
Spanish channel or the English channel, and they have
Démosles
to go
un
to the
ratico
Spanish
para que se
channel.
cambien de canal.
Ahí está, perdón,
You
pero
can change
como
your
hay
channels.
varios que no
Okay.
están mencionando que no. Claro, los que
Some are
escuchan probablemente
mentioning
sea
that
porque están en el
those
canal
that are
neutral.
listening
No sé
well
cómo
are
es.
probably
A ver si la
in
gente
the
de traducción puede eso, que se coloquen en el canal general.
okay.
Es eso.
Yeah, they can go
Bueno.
to the
Alejandro, ¿nos está escuchando bien? Alan,
original
¿también?
audio.
Sí,
Alejandro, Alan is listening,
Ok.
can hear
Dime
well.
si seguimos.
Okay. Okay.
Continúa.
Tell me if we can go
Okay.
on. Yes, please continue.
Y más allá de esta crisis del sistema de
Okay.
salud, que como
Beyond
les digo,
this
está
healthcare
en toda la región,
crisis,
pues también tenemos noticias de
which is
cómo
all
mueren
over
los
the
niños
region, we
no en las
also
mejores
have
condiciones.
news on how children die not in the best conditions. The World Health Organization insists in the fact that children require a differentiated approach. We shouldn't apply protocols as adults. Pediatric units should not be measured in the same one as adult ones, in the same way as adult ones. And we should do advocacy so these pediatrical units do not close so we can guarantee good health care and better conditions at death. Most children don't die of cancer. They live with a serious disease for years. This is what we see in this graph. Metabolic diseases, prematurity, problems during birth, HIV and other chronic diseases are much more prevalent than cancer, and they represent or they account for a larger disease burden. 81% of SHS burden in 2023 correspond to children who survive and live with their disease. This means that we need sustained symptom control, specialized teams, well-trained teams to help control these symptoms, facilitate the disease trajectory, and even in the transition to adult age, and favor a good end of life in case this happens. So what's important is that relief exists, solutions exist, but we lack access. This is a study I invite you to read because it's very interesting. Dr. Julia Downing from the Lancet Commission states that it would be enough to have $1 million per year to cover all the drugs who would relieve the pain of all children from 0 to 14 ages in low-income countries. This is not expensive and not complex, and there are many institutions that are developing projects to cover this issue. IAHPC did an important study on the essential medicine package required by adults and children at the end of life. The St. Jude Hospital is also working on an access platform for children with cancer. And we hope this also covers symptom management ahead. As I said, 93% of deaths of child deaths related to SHS in low-income countries are avoidable, according to the Lancet Commission. We know these figures very well. 80% versus 20% children survive to child cancer in richer countries as compared to LMIC, where we have least resources, we have most needs. The literature has made an excellent work by estimating how many children require palliative care. However, we know very little about how they die and where they die. We know that most die in hospitals due to studies in high-income countries, but we don't have exact data for our region. We don't measure symptom control, dignity, the presence of families at the end of life, or care that agrees to patient and family objectives, and particularly measuring that children die in the place they would have chosen together with their families. This is a research gap we need to cover in Latin America and the world. What is documented and where do we have figures? We know that survival of patients with cancer and other diseases is higher than in high-income countries as compared to low-income countries. We know that patients with cancer have access to PC is higher in richer countries as compared to those in poorer countries. So there is an important gap in terms of pediatric hospices in Latin America. They are almost non-existent. I got to know one in Chile, another one in Mexico. They're building a beautiful one in Peru, but we need more. This isn't enough. Most pediatric deaths happen at hospitals as as is the case in high-income countries, and there is no regional record comparable comparable one that can provide us with figures on this. The experience in the hospital, Fundación Valle de Lili, we did a retrospective study before the pediatric palliative care program. We chose 100 patients at random who died in the hospital with threatening and limiting factors, and only 11% obtained palliative care. As for adults at that point, 90% died in intensive care units, 85% with mechanic ventilation and vasopressor support, 72% with failed RCP, and less than 10% with survival days. In 2016-2017, we implemented the pediatric palliative care program, leading it with a multidisciplinary team. And then we said, how can we make sure this program has an impact? So we did another retrospective study, including 253 clinical records or medical records, and we evaluated interventions in the last 72 hours of life. We divided those who received exclusive care for pediatric oncology and those that received joint management by oncology and pediatric palliative care. 94% died, and there was psychology intervention. 70% had social work support. 79% had an advanced care plan and even better control of anxiety and agitation at the end of life. Although this study is not perfect, we have started seeing impact of having palliative care, and that our patients definitely change the history of palliative care when there is work done by these joint teams. Questions no one can answer: where are children in Latin America dying? At home, in the intensive care unit, in hospital rooms, in emergency care units? Was the family present? Were they during the last moments and even following grievance? Did they receive a care that agreed with what they wanted? Did they die with controlled pain and symptoms? As we know, there are symptoms of studies of symptom control, but very few in our region. Were those care targets discussed? What is the comparable indicator to start to respond to these questions? And then the place is important, but the experience is much more important concerning how our patients die. Here we see the proportion of patients dying at hospitals in Latin America and in high-income countries. As I said, it's mainly at hospitals and not so much at home or in hospices. And here the question is not only where a child can die at home due to system abandonment and not by choice. One of the greatest challenges we face at hospitals in Colombia is that there are no guarantees of symptom control or good health care when patient goes back home because there's a lack of outpatient care. So how is the port of entry?
Y aquí me gusta traer una frase de Edward Deming, el padre del mejoramiento de la calidad, en donde dice que
Here we have a sentence by Edward Deming. He says that we cannot improve what we do not control, and we cannot control what we don't measure, and we cannot measure what we do not define. So actually, there's a lot to do. And to finish, I would like to share with you what we are doing at the St. Jude's Global Program for Palliative Care, in which we put events into action. And I want to share two important projects related to the end of life care. First of all, we have PROTECT. It's quality indicator assessment for the end of life in palliative pediatric care. We have 73 prioritized indicators, and the most important thing is that this prioritization has been done with health professionals, but also with families that are going through grief. And we can see what are the improvement opportunities or the strengths according to if it was the health team or the family team. And in the pilot, we had 4 institutions from Latin America that I'm going to show you later on. And then we have the HEAL package, which is a package to improve quality. And I'm going to tell you, and here we seek to increase the amount of children that receive high quality care. And so there were 13 hospitals participating in the PROTECT project pilot, but I'm going to show you only the results from these 4 hospitals in Latin America, Mexico, Haiti, Colombia, and Ecuador. And what we can find here is that the end of life care module is the only one in which hospitals didn't have strengths. This means that the end of life care was a common weakness between these 4 hospitals. And you can see this in this polar graph in which light blue represents end of life care. There are other modules that this PROTECT project includes, like, for example, ethics, multidisciplinary teams, symptom control, among others. But I wanted to tell you about this. And so, main shared opportunities in these 4 hospitals in Latin America. We need support for grieving families, palliative care from the beginning of the illness and during the last 3 days, economic care for funeral expenses, and preferences for the death site. And it's also very important to being able to provide health care independently from the place, from the site. And we go from the where to the how. Healing through end-of-life care and assistance for the loss of the child is a package to improve quality based on evidence. It is scalable and with its own measurement strategy. It was designed by some experts, but it also includes experts from all over the regions of the world, including grieving parents, and they helped us co-design this package. It was born in the Cali Valle de Lili Hospital in Colombia, and today we have the pilot in 8 institutions, out of which 2 are in Latin America. This package has 6 components that are anchored in compassionate communication, and it has several clinical scenarios. First of all, we have death. It can be anticipated. We can predict it. And then we have the other type, and we're measuring, and then we have sudden death, and we're measuring in both scenarios. And then we have a discussion on care goals, prioritization of comfort measures, compassive and private environment, creation of memories, and heritage. And we know that palliative care does not finish when the patient dies. It goes well beyond during the end-of-life accompaniment. HEAL seeks to measure what I had told you before, and that we have not been able to measure exactly. We have 2 data collection forms and 17 indicators divided in process, result, and balance measures. I'm not going to go in detail, but this is some preliminary data. We have 8 teams. We have 249 data points, and this is how the trend graphs are going to look like for these indicators. And we hope to see in almost real time how we are caring for the child at the end of his or her life and how the family is perceiving this experience. And I hope that we will be able to give you more positive results, the impact of this project, and to finish, I would like you to take these 5 ideas home. The problem is huge and it's focused in these 10.6 million children that need palliative care, most in low and middle income countries, in which only 5 to 10% has access to these services. We measure how many, but we don't measure the how. We know how many children need care, but we don't measure if they die with pain, with dignity, and if they can choose the place of their death. And here we have an important research gap. Fragile systems decide for the child. The health crisis is more and more prominent in our region, and we have services closing, and we need to do much more advocacy and work in this sense. The place of death is a measurable proxy. It is available, it is comparable, and it reveals access in terms of palliative care. However, we need to have regional registries that will help us measure this with more exactness. And HEAL goes from the where to the how, and it will help us look in real time. It will help us implement real-time strategies to improve end-of-life care for children in a region. Thank you very much, and we will answer your questions in the end.
Muchas gracias, Jimena.
Thank you very much, Jimena. It was very interesting. The presentation was very interesting. And now we're going to welcome Catherine Pettit. She has a PhD in political theory from Columbia University, and she has also studied in the University of California in San Diego. She works at IHPC as a senior advocacy and partnerships director. She goes to meetings, to UN meetings, to advocate for the use of palliative medicine. She tackles, I'm sorry, but the speed at which she is speaking does not allow us to interpret. And she works for the equitable inclusion of people with different degrees of vulnerability, people in prison, people with disabilities, indigenous peoples, and people affected by humanitarian disasters. Catherine, welcome, and please go ahead.
Thank you, Veronica, and thank you to PAHO for hosting this and for that kind introduction. I'm very honored to be with you all today, and we're very happy that IHPC is partnering with PAHO, the OPS, in this very important work. I'm just going to give you a bird's eye view of public health palliative care advocacy, which is really what we would call the essential connective tissue to begin to implement the public policy that's needed, as we heard from the last two presentations, and the service provision that can only begin by addressing the issues we've heard about today. So this is a very quick tour through what's a huge issue. We're going to go through some definitions, talk about the international, regional, and national normative frameworks. Those are the frameworks of the laws and policies, and how those can be implemented at the national and subnational levels, and then some takeaways at the end. So it's always important to start with definitions, as Jimena's slide said, that we need to have things being defined so we're all on the same page. And you can also find these definitions in full on our website. Palliative care and serious health-related suffering. So palliative care is the active, holistic care of individuals across all ages, so of course children, neonates, and older people with serious health-related suffering, SHS, due to severe illness, and especially those near the end of life. And then SHS, serious health-related suffering, cannot be relieved without medical intervention, and when it compromises physical, social, spiritual, and/or emotional functioning. due to severe illness. So those are the two basic definitions we're going to be building this presentation on. As I said, on our website, there's the full definition of palliative care with a whole lot of recommendations that governments need to do in order to implement and operationalize the definition. A definition doesn't do us much good in terms of policy unless governments know, and civil society organizations and regional organizations like PAHO know how to operationalize it. And I've just picked two of those suggestions to talk about today. So the definition goes on to stipulate that to achieve palliative care integrations, governments should adopt adequate policies and norms that include palliative care in their health laws, national health programs, and national health budgets. Very important. We've got lots of countries with policies, but no budgets. And then second, to ensure access to essential medicines and medical devices for pain relief and palliative care, including pediatric formulations. So those are the basic things that we're going to be talking about today in terms of the definitions. And finally, public health advocacy. What's that? There are many definitions you can find if you look for them online. I just picked this one because it's relatively brief and useful. It's the process of gaining political commitment for a particular goal or a program, and the process is what's really important, which is identified by some as a critical population health strategy. And so in our case, of course, the critical population health strategy is to have sufficient and affordable and accessible palliative care services for people in need. So advocacy is an institutional activity, unlike activism, which can be conducted by, activism can be conducted by individuals with non-registered activist groups, but advocacy is always, if it's effective, conducted by institutions that are registered and chartered with the state usually. Some authorities say that advocacy for their patients is part of the job description of all health professionals. It's an ethical obligation of health professionals to advocate for their patients. So the other thing I'd like to point out is the relevance of research to advocacy. And we've obviously heard from two researchers today, but it's absolutely relevant to advocacy and to public policy and to implementation. And the papers we've heard today and the one by Tanya Pastrana, IHPC's research advisor, says explicitly in the background that knowing where people with cancer die and understanding the factors that affect it are public health issues relevant for the development of policies that ensure the provision of adequate end-of-life care in alignment with the patient's needs and preferences. So that's the end of the quote. And evidence is essential to effective advocacy, as is lived experience of patients and caregivers. So this graphic shows the pathway I'm going to try and trace for you today, beginning with the international commitments, which have come from IHPC advocacy with our partners for the last 2 decades, through national legislation and frameworks, policy and implementation plans, sustainable financing, health system strengthening, which of course is going to be very important to integrate palliative care into the health system. And then very important, this number 6, intersectoral and community partnerships. It cannot be done without that. And then people and communities with timely access to quality palliative care is the goal. And these are the better outcomes that we're looking for. So IHPC is working on all these domains, all 7 of these domains, and we appreciate the help and support of PAHO and all the WHO regional offices we connect with, as none of us can do this alone. So we've learned from advocating for improved availability of palliative care services for the last couple of decades that laws and resolutions we achieved, which I'll go through in a minute, that commit governments to providing palliative care for populations are necessary. They're absolutely necessary to have a policy framework, but they're not sufficient. And that has taught us what I'm going to go over with you today. So most of the laws, the international conventions and the treaties and the resolutions, they're not what's called in international law self-executing. They won't just happen by themselves. Governments don't just wake up one day and think it's a good idea to have a palliative care policy. They have to be advocated for by folks like yourself, those who are on the call, and all the partnerships that you make to make it happen. So this is the list of texts that constitute the international framework that authorizes and promotes and urges palliative care approved by all the world's governments. That's the multilateral framework. It includes human rights conventions, treaties, reports, and resolution. There's now an established right to palliative care as part of the right to health. It's not a standalone right. There's, of course, WHA, World Health Assembly Resolution 6719, the Palliative Care Resolution, which was mentioned in the first presentation. That's from 2014. Agenda 2030 Sustainable Development's important. That was approved by the UN General Assembly in 2015 because Target 3.8 includes universal health care and access to essential medicines. Palliative care is included under universal health coverage, and we have palliative care essential medicines. So the Agenda for Sustainable Development, all governments have signed up to that, and all governments really care about that. So that's important for advocacy. The UN General Assembly Special Session on the World Drug Problem, the outcome document in 2016, has a whole standalone chapter on improving access to palliative care medicines. We work very hard on that, and that can really help member states to improve availability, access, affordability, if they follow those recommendations. The Declaration of Astana on primary health care in 2018 includes palliative care as primary health coverage as part of primary health care. And the political declarations, there are a bunch of these that are in the UN General Assembly since 2019, I think, on universal health coverage, NCDs, HIV/AIDS last week or the week before. All of these have 2025 and 2026 iterations, all include palliative care. The latest one on universal health coverage actually has 5 mentions of palliative care, including pediatric palliative care. The Pandemic Treaty, which has been approved also by the World Health Organization, includes universal health coverage in primary care, and that, of course, as I've said, includes palliative care. So the Pandemic Treaty is very important because we all remember COVID and how palliative care was sidelined, often absolutely necessary, but still sidelined in a lot of health systems. And then we're working right now as we speak on a new binding international convention or treaty on the rights of older persons. And we'll make sure that palliative care is included in that. So you can all leverage at a national level through your national associations this international framework through your own advocacy. And I'm going to go to talk about that. At the regional level, the cornerstone regional international law, and it's binding international law, it's not just an optional resolution, which includes palliative care, is the OEA Convention on the Rights of Older Persons, which explicitly includes a right to palliative care in Article 6. which says that governments shall take steps, and all these ellipses are where I've cut out text just to have enough the words that we need on the screen, but that all governments shall take steps to ensure that all institutions offer palliative care and prevent unnecessary suffering. And that's for older people. So that would ensure that people can die at home with the necessary support. And 12 states parties, that means governments in international law, as you see on the far right of the slide, have already approved this treaty. That means they've bound themselves to do this. And you can also leverage this in your advocacy, and there's an enforcement mechanism at the Inter-American Court of Justice, which I don't have time to go into now, but it's very important for the region. So the national normative frameworks, you talked about in Brazil what the normative framework is, and many countries in the region have national laws and palliative care strategies. Your national association should know about these laws, and you can find out more if you need to in this 2025 Atlas of Palliative Care in Latin America. Check with the ALCP, because they should have a database on the national legal frameworks. And also, if you really want to deepen your understanding of your own country's framework, partner with a law school or a policy faculty at a university and have them review the existing legal frameworks governing access to palliative care in your country. It may only be an NCD strategy at this point, and your legal framework may need to be updated to align with the regional and global frameworks, because that's really the ideal, that all the jurisdictions and levels align with one another. So national policy advocacy is necessary for palliative care development in your state, country, or district, or even locality or neighborhood, because governments are the gatekeepers of public health services and availability of controlled medicines under public health and drug control laws. And because drug control is international law and governments are the gatekeepers. You have to advocate with certain elements of your government, not just the health ministries, but also with drug regulators and supply chain components in your governments for the controlled medications. To do that, you need to build a coalition in order to propose adequate legal frameworks and to get your proposals funded. Services and medicines cannot only be available in the private sector for those who can pay, or for the lucky few who have insurance policies that cover palliative care, or who live in a place where there's a charitable institution that provides it for free. It has to be part of public policy. So you have to help governments implement all those normative commitments I talked about in the beginning, and to integrate palliative care into the wider public health system and society. You need to involve community, cultural, and private sectors. You need to partner with them to improve patient and caregiver well-being, because advocacy objectives are to help national governments implement those normative commitments, to integrate palliative care into the wider public health system and the society, to involve all these different sectors I just mentioned, and the outcome of that is to improve patient and caregiver well-being. That's why I said this is complex, but it can absolutely be done. So I want to talk about some challenges, some of the limitations to public health palliative care advocacy, which we try to resolve through community-level partnerships and education. It's not an exclusive list. But there's low palliative care literacy in community and public authorities. That means that very few people know what palliative care is or really understand it without having a lot of the misconceptions. Public health authorities have few fiscal resources. They always say there is not enough money. So your advocacy has to show how it can be cost effective in the end, even though there's often an initial investment. So public health authorities have few fiscal resources, and at the system level, we know that health systems and hospitals especially were built for trauma and disease control rather than chronic disease maintenance. Plus, most of those are at capacity. There are epidemic rates of health worker burnout at the moment, and the health workforce is insufficiently trained to provide palliative care. There is a lack of palliative care association capacity to do advocacy. Many people don't understand what it is and how to do it. And IHPC is trying to help with that through our courses and our mentoring. But it's a daunting list. But advocates can use the resources and assets of the community and these fragmented community civil society organizations and services as an opportunity for their advocacy. They can see the situation and then take some of these practical steps that we're going to go to very briefly for how you could actually start doing advocacy. So first of all, and I've done a little bit of this with you, you can review the global, regional, and national normative frameworks authorizing palliative care. It's important to know your enabling legal ecosystem. Then you want to map individual and institutional circles of influence and include national and regional universities, professional associations, other specialties, allied disciplines, and civil society organizations. Who can you influence? Who do you know? Who has power? And just some of these are ALCP, the Compassionate Communities. There's lots of them in Latin America. So you make these circle of influences at the start and then assess your institutional capacity to achieve the partnership goals and objectives for policy that you want. Know your limits and know your capacity. And it's important to identify an advocacy focal person in your organization. This is not something you can just do in your spare time if you really don't understand how to do it. Next, you need to compile evidence. This webinar is a good start for it. So once you've clarified your circles of influence, you collect evidence and you're going to map existing jurisdictional assets and deficits, including evidence of need. We've certainly heard a lot about that today in the public health system. Collect and archive stories, personal stories of patients and caregivers who've received palliative care and who have not received palliative care. So you want to have a database of personal stories, photos, and videos. And then you're going to draft an advocacy strategy that's aligned with your national commitments and the international commitments. And this is where you need the institutional capacity or to belong to an organization like IHPC, which has that capacity and can support this kind of advocacy mapping. And then you want to build support for your strategy with your association and with partners through public campaigns and private influence. So as I said, we have lots of assets and resources in the world now, the palliative care world. So you should familiarize yourself with the WHO and PAHO resources, since governments tend to pay attention to the authority and legitimacy of those technical documents. There's a new guideline that was published last year on access to controlled medicines and policies for rational and safe access, and a whole set of guidelines on palliative care in emergencies, palliative care in pediatric care, palliative care in primary health care. So WHO has a lot of resources. This is the Left Behind in Pain, access to morphine all over the world, what the blocks are, what the triggers are, how you can improve it. This, of course, is the WHO model list database, which is online. Check your model lists of essential medicines. Do you have all the essential medicines in Chapter 2 of the model list, which are the pain and palliative care medicines. So these are authoritative documents your government has approved, whether your officials know about it or not. But your advocacy will remind them that these exist and bring these resources to their attention. Then familiarize yourself with the IHPC resources. We have a very rich and varied website with all these resources, most of which they're all free and open access. We have the essential and expanded palliative care packages, which list the minimum components, including human resources and medicines that you need for basic and expanded palliative care provision, depending on your country's income level or resource level, or just your institution's resource level. Let the packages be your guide. And there's a whole article about that. Tanya was the lead author on that on the website, and I'll be producing a short video on how to advocate for them. There's a handbook on how to dose and use those essential palliative care medicines with an app that you can use at the bedside. We have publications on getting started guidelines for hospice that's been downloaded thousands of times. We have this database of educational institutions which you can add to, which you can use to find partners in your advocacy. And then finally, I have an advocacy course on the international framework and how to do advocacy. So some takeaways: serious health-related suffering, which we began with in all jurisdictions, is the catalyst for advocacy. That's what's going to motivate your advocacy. Public policy and community partnerships promoting palliative care through advocacy can relieve serious health-related suffering. National governments should align their policies with global normative frameworks stipulating universal palliative care access. As I said, though, they're not going to align their policies without advocacy at the national level. And then finally, effective advocacy requires sufficient institutional capacity. Here are some selected references from what I've talked about. And thank you, gracias. And I'm going to close with a quote from Margaret Mead, the cultural anthropologist, who said, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has." And that's what we're trying to do at IHPC by partnering with all of you. So thank you very much.
Muchísimas gracias, Catherine. Muy interesante.
Thank you very much,
se ha llenado de
Catherine.
mensajes,
Very interesting.
pidiendo
We're full of
más
messages
detalles sobre los
requesting
materiales.
more info
Bueno,
on the
creo que
materials.
I
I think we have just a few minutes to exchange some questions and answers. Since we have little time, I'll group them a little bit. And I tell everyone who requests materials that we are going to let you know how those materials will get to you. Some people ask how to access the app. Yeah, I see the answers are coming up in the chat. I just put the message, the link in the chat. Yes, thank you. Since this will be available, if you listen carefully and you take a look at the slides, perhaps you can get access to guidelines, links, etc. So questions. Two or three questions are related to the place of death as an indicator of access to palliative care. And they ask about how we can compare or consider place of death versus patient or
Magdalena
parents'
también mencionaba, por ejemplo,
preferences.
que muchas veces los
Magdalena
padres,
also
en el
said
caso
that
de que sean
oftentimes
niños con una
parents,
enfermedad
in the case of
avanzada, prefieren estar en el hospital.
children who
Entonces dejo estas dos
with
preguntas en el aire.
serious
¿Cómo ven ustedes,
diseases
al lugar de como
prefer
indicador
children to
versus
be in
medir
hospitals?
preferencia por
How
lugar de
can
cuidado
we then
y
measure in terms of
el lugar de los
preference?
padres en el caso de los chicos, ¿no?
Pero pues puedo ir primero por el lado de los
I'll
padres
go
y de
first
la población
on the
pediátrica.
parents and the pediatric
Yo estoy
population.
definitivamente de acuerdo.
I definitely
Creo que
agree
es importante medir dónde mueren,
in the
pero se
fact
queda
of
corto el
measuring
indicador,
where
¿verdad?
people
Y
die,
sí
but the
tenemos que empezar a medir
indicator
la
is
preferencia de la
not
muerte
enough, and
y
we
sobre
need
todo
to
el
start
cómo mueren
measuring
los niños.
preference
Porque tenemos
for
el
place
caso
of
de que
death, and
la
particularly how
familia, el
children
paciente y su
die,
familia, por ejemplo,
because
quieren irse a fallecer a
patients
casa en una
or their
vereda
families want to
lejana,
go
con poco
back
acceso a
and
salud.
die home, but
De
there's
pronto no
little
tenemos
access to
medicamentos,
health
no
in that
tenemos un
place. We don't have
sistema en donde
drugs.
ellos
We
puedan
don't have a
consultar
system where they
fácilmente
can
en caso de que algo se
get
salga
a
de control, como
doctor
normalmente
easily if
pasa al final de la
something
vida.
is out of control,
Entonces tenemos
as
que
it
evaluar
usually happens at
eso
the end of
también, no
life, and we
solamente que
also have to
podamos
evaluate that. It's not
favorecer sus
only that
preferencias, pero
we
además
can favor
garantizar
their
una atención en
preferences, but
salud
also
de calidad
guarantee
al
quality
final de la
health
vida.
care at the end of their lives.
De acuerdo. No sé, Fernando,
Yes,
si
I
tienes algo
agree.
para agregar.
Fernando, do you have something to add?
Well, I believe that when we see alone the place of death, of course, it's not an indicator that we can see in alone point of view. We have to consider the preference, but also what kind of services are provided in those conditions. For example, if the health system can be able to provide some home care or hospice access, or even in hospitals, how is the end of life in those institutions? Because what we can see in Latin America is that it's not what we have today is not a question of options, but what people can reach. In fact, we have many places and countries which are struggling to provide access to formal care, professional care, not even palliative care yet, but professional care in basic support for our communities. So we have to advance not only with the palliative care services, but also with social and economic developments in those places, especially the more vulnerable places.
Gracias. Catherine, I don't know if you want to add anything.
No, one of the things I was really interested in Tanya's article also on place of death that I showed, which nobody, I don't believe, discussed this, was the importance of being able to get a death certificate and how that really affects policy. I'm not policy, but the fact that even if people could perhaps die at home without too much suffering, because it's so much more complicated to get a death certificate at home, that they will then go to the hospital to do it. It's much less complicated. It's the same in Spain where I live. It's much more complicated. The police have to come to the house, and it's a big production. And I think that's important for policy because there could be ways that there could be advocacy for a more let's say, user-friendly policy around death certificates, which seems like such a small detail, but has such huge repercussions for families.
Tania, ¿tú quieres decir algo?
Y gracias, Verónica. Bueno, desde los estudios que hemos hecho con
Yes,
muchas de las
thank you,
personas que están
Veronica.
aquí,
In the
pues,
studies we have made,
latinoamericanos, siempre en
um,
conversación y
and
analizando los
always
datos,
in conversation
para
among
mí el
Latin
lugar de muerte es,
Americans and
como dice la
analyzing
doctora
data,
Bárbara Gómez, la
as
punta del
Dr.
iceberg,
Barbara Gomez
porque es lo que
says,
está mostrando.
place of
Hay un
death
montón
is
de
the
cosas que
tip
están
of
por
the
debajo sin
iceberg
cuidado.
because there are
Los
many
niños, por
things
supuesto, no quieren morir
that
fuera sin cuidado.
are not only connected to care in hospitals. People go to hospitals according to a specialist to receive some kind of care with the hope of receiving some kind of care. But all those who have worked in hospitals know that the care they're looking for is not what they will receive in hospitals, and there are no palliative cares. There's no palliative care in hospitals that deal with acute issues. So we need to understand where the people are, what's happening, and we need to train people there where people frequently die. And if they are lucky enough, they will get personnel that are knowledgeable of palliative care. And I know that from my own family, who have not received this kind of palliative care they needed in hospitals. The thing is to die with the right care, not only at home, but also at hospitals. There are problems in the healthcare system, and we have to check training, access to service, money, transportation, many things that are around this issue.
No, al contrario. Gracias a ti. Y también está
you.
interesante en el chat que hay
In
Diego
the
Escobar
chat,
de
we
Chile,
can
Marlene
also see
Goriburu
Diego Escobar
de
from
Perú
Chile, Marlene
y
Goriburu from Peru, and
Mercedes Real de
Mercedes
Ecuador,
Real from
que
Ecuador,
también están
who
comentando
are
acerca de ciertas
commenting
posibles
about
soluciones que ellos
some
fueron
possible
encontrando en los tres
solutions that they
países,
found in the three
acerca de, por ejemplo,
countries
establecer planes de
around
cuidado y ver cómo
establishing
esos planes
care
si se
plans,
respetan o no, como una
and if those
medición,
plans are
formar
respected or
brigadas de
not,
atención
also measuring
domiciliarias en donde
that,
se
also
facilita la confección del certificado de función,
organizing
calculo y la atención,
domicile
y lo
brigades
mismo también
for birth
fortalecer el enlace
certificates
entre
and
hospitales y el primer nivel de
care
atención. Digo, todas
quality, and
estrategias
also
que nos pueden
strengthen
ayudar
the
a
relationship between the
mejorar
homes
el
and
indicador,
hospitals,
digamos, ¿no?
strategies that
Sí.
can help us improve the
cuidado,
indicator, and strengthen communities for care, because we know that most patients need care that is in the hands of the community. 95% of patients are within their community, so we need to train the community and strengthen them so that they are able to care for their own people.
Muy bien.
Okay, very
No sé si
well.
tenemos tiempo,
I don't know if we
díganme
have
si
some
tenemos tiempo
time.
para un tema más
Let
o ya
me
estamos.
know for one
Ok.
more topic.
Ya enseguida termina el trabajo de traducción y creo que necesitamos hacer el cierre.
Okay,
Así que nos quedaba
translators
una
will
discusión que la
go, so
dejo
we need to
planteada para
close.
que la sigan
We have
pensando
still
acerca
a
de
point of
otras cosas
debate
para medir que no sean
about
solamente
other things to
el lugar de
measure,
muerte, sino
not
también, por
only
ejemplo,
place of death,
la
but
carga
also
emocional o similar
emotional
que conlleva el cuidar en casa a un
charge,
paciente
or
y cómo
the
se
similar
mediría eso, etcétera.
burden
Pero bueno,
of
queda
taking
planteado
care
quizás
of
para algún otro
patients at
seminario.
homes and how to measure
Y le
that.
vamos a dar lugar entonces a
That's for
Silvana para
another
que haga
seminar,
el
right?
cierre.
Now,
Muchísimas gracias a
Silvana,
todos
please
por su
close the
participación.
session. Thank you very much for your
No,
participation.
muchas gracias,
Thank you very
Verónica,
much,
y muchísimas
Veronica.
gracias a
Thank
todos
you
y
very
todas.
much
Hemos
to
llegado
you
a este
all. We
momento de
have
concluir
reached
este
the
excelente webinar
conclusion
sobre
of this
cuidados
excellent
paliativos.
webinar
Yo
on
soy
palliative
Silvana
care.
Luciani, la
I'm
jefe de la
Silvana
unidad de
Luciani. I
enfermedades no
head the unit
transmisibles
of
de la
non-communicable
OPS aquí en
diseases
Washington,
at
D.C.
PAHO
Y es
here
un placer y un
in
honor
Washington, D.C. It's a
acompañarlos a
pleasure
todos
and an
en este
honor to
webinar
be
para
with
hacer
you
las
at
palabras de
this
cierre.
webinar for
Y quiero
these
empezar
closing remarks.
agradeciendo
I'd like to
profundamente a todos
deeply
ustedes por su
thank all of you
participación.
for your
Tuvimos ya
participation.
más de
We
500
had more than
participantes de toda la región
500
de las Américas
participants
y
from
afuera
all
de
the
la región.
Americas
Tuvimos
and
gente de
outside the
India,
region
Bangladesh,
too. We had people
Philippines, South
from
Sudan. So
India,
thank you to our colleagues from around the
Bangladesh,
world for joining
Philippines,
us on
South
this webinar.
Sudan.
Y fue realmente un muy agradecido espacio para comprender sobre el lugar de
So thank you
fallecimiento
very
como
much
un
for this
indicador
forum
del
to
acceso a cuidados
understand the
paliativos
place
en
of
América
death as an
Latina.
indicator
Quiero también agradecer a
regarding
Verónica
palliative
Pichel por
care
su
in Latin
excelente
America. Thank you very
moderación, por
much,
supuesto, en
Veronica,
el
for
webinar,
your excellent
y a todos los ponentes por
moderation,
sus
and
excelentes
all the
presentaciones,
lecturers for their
y también a
excellent
nuestros socios de
presentations,
la
and
Asociación
also our
Internacional para el
partners at
Auspicio y los
the
Cuidados Paliativos y a St. Jude
IAHPC
Children's Research
and
Hospital
St.
por su
Jude's
colaboración en este webinar.
Children Hospital for their collaboration in this webinar. We have listened to many initiatives, examples, and information. We started with the Brazil example on how they have developed the palliative care policies at the SUS, taking advantage that there was a global resolution on palliative care. We have heard from the St. Jude Hospital on PC in children and specific strategies for children, and the program they have an excellent tool. And also the IAHPC about advocacy and how we can strengthen this integration of PC in healthcare systems. And I think this dialogue reaffirms all the importance in the region of strengthening healthcare systems to improve availability and accessibility of palliative care services, and also center our attention in dignity, support, and families. Your presence, very impressive. More than 500 people. This shows the commitment we have in the region with an agenda seeking to reduce inequities we have all over the region and to promote universal access to palliative care, including essential medicine for pain relief. I hope this debate triggered new regional cooperation and work lines. PAHO is committed to continue collaborating with ministries of health, professionals, and of course our partners from the IAHPC and the St. Jude's Hospital to have access to palliative care for both adults and children, and to continue promoting this forum to exchange regional experiences. Today's webinar is part of a series of webinars that we will organize to strengthen this community of practice and to continue sharing experiences. So we invite you to keep in touch with our future activities. I'd like to repeat that what we discussed today does not end today. It's a starting point for our new alliances and joint learning. So thank you very much for your time, your interest, your dedication, and let's keep in touch. See you in our next webinar. Thank you very much.
Chao, chao.
Muchas gracias a todos. La verdad que estuvo súper, súper lindo.
Thank you
Gracias,
very much to
Silvana, por
everyone.
venir.
It
Gracias,
was
Verónica.
great. Thank you very much,
No, por
Silvana, for
favor,
joining.
gracias a ustedes.
Thank you, Verónica. Thank
very much,
you
Fernando.
all.
Gracias a todos. La verdad que es súper interesante. Como mencionó Silvana, más de
Thank
500
you all. More than
personas
500
conectadas.
participants, as Silvana said,
Súper lindo. Un gran
was
comienzo
super.
para esta serie de
A
webinars.
great start for this series of webinars. Yes, that's right. Thank you very much, Claudia, for organizing this. Liliana, all those involved in the organization of this excellent webinar. Thank you very much for this forum.
Gracias a todos. Que tengan un
Thank you
excelente
all.
día y bueno, seguimos
Have an
en contacto
excellent
entonces
day,
para
and let's
organizar el
keep in
próximo.
touch
Gracias.
to organize the
Thank
next
you very
one.
much.
Thank you.
Bye.
Fernando. Bye.